Hi there, this is Jim Collins from cardiologycoder.com, and today we're going to explore all the exciting changes that are taking place to cardiology coding and billing effective January 1st of next year, 2012. When we look at the changes that are taking place, most of them are kind of focused in on one specific procedural area, that being pacemaker and defibrillator surgeries. However, there's a handful of other changes that are also important to be aware of. One of the changes is that we've seen a small collection of ICD-9 codes added, which may be useful in some cardiology groups. I don't think these are going to substantially change the way that we bill for services. It just kind of gives us a little bit more flexibility in reporting things that are taking place. So you can see there's some new coronary atherosclerosis. There's one new atherosclerosis code, a couple of cardiomyopathy codes. These are all relatively self-explanatory, so I really don't want to spend a whole lot of time reviewing each and every one of those, but they're in your handout material. And just make sure that if your doctors are addressing these issues very frequently, that you update your billing sheets, your charge capture forms, so that they can assign those when appropriate. Stress echocardiography hasn't really changed as far as the codes that we're going to be using. However, what the American Medical Association did this year was kind of created a little bit of confusion, and it'll still take a little bit of time to figure this out. So, these books were just recently distributed, and there's not been a lot of guidance out there from anybody. But one of the things that's in the 2012 book is that it says when all of the professional services of a stress test are not performed by the same physician, which is very specific verbiage. They say performing that the same physician, that the appropriate codes, and then they list out the individual components of the supervision, the interpretation, the report for the stress test should be reported by the physician who actually provided each of those components. This, of course, is a big challenge if indeed the AMA has the ability to force us to bill these services in this way, and if that changes what an accurate claim is, simply because the way that most cardiology groups operate is that one physician is designated as the supervising physician for office-based stress tests, and another physician, oftentimes, who really wasn't available to supervise the test, is the one who actually does the interpretation, and that interpretation may take place a day or two later. Back in 2006, Medicare clarified this for cardiologycoder.com and told us basically that there's nothing specific that requires the doctor to split the bill. If the service was provided by the office and the equipment is the physician's, then both components can be billed within the same group practice, effectively giving us clarification that the way that we've been billing these services for decades was appropriate to do, meaning one doctor could do the supervision, another doctor could do the report, as long as they're both in the same group and the practice is providing the entire service. We essentially have this flexibility to report the service under either one of the physicians that was involved. This guidance from the American Medical Association in CPT 2012 is in stark contrast to that. So we'll try to get them to clarify. I think we want to keep following Medicare's guidance, because there's numerous places where there's instructions in the CPT book, and Medicare has consistently and repeatedly said, the standardized code set includes the CPT codes and definitions, but not the introductory text, not the instructional notes that are in the CPT book itself. Of course, they pick and choose when they want to enforce that interpretation, and if there's a parenthetical note that would trigger a denial of a claim, then they tend to follow it. And if there's a parenthetical note that would trigger payment for something that Medicare thinks they can get away without paying, then they'll say, the standardized code set doesn't include these rules. So it's not really a fair game that they're playing. But as I mentioned, as I'll mention at the end of the call here, there's a way that we can really facilitate resolution a lot of these contradictions, and I'm going to help everybody understand how they can individually participate. Observation care codes, these were changed last year in that they gave us new subsequent observation care, and what that effectively does is it makes it so physicians are not in the position of making a snap judgment within 24 hours of the patient being admitted to OBS if the patient needs to be admitted to inpatient status or if the patient can be discharged home. This 24-hour observation rule is something that's been there for quite a while. And of course, what it had the impact of doing was forcing physicians to just admit patients to the hospital if the physician felt the patient needs a little bit more attention, a little bit more, careful nursing care in the inpatient setting, or in the hospital setting rather. If they were going to go over that 24-hour mark by a little bit, the physicians were effectively forced by Medicare policy to admit those patients to inpatient status, at which point the reimbursement that the Medicare system has to pay for these patients skyrockets. If we treat a patient in the outpatient setting, Medicare may pay less than half of the dollar amount that they would pay for the exact same services if the patient had actually been put into inpatient status. So last year they changed the observation care guidelines so that you could admit the patient to observation and then follow him in subsequent observation care for multiple days before actually discharging them. What they didn't do, though, was give us time increments for the initial observation care services. And what we see is that they gave us these in CPT 2012, and they made these match the codes, or I guess rather the time guidelines that applies to the codes for initial inpatient care. So the first, the second, and the third levels of observation admission are in direct correlation with the minute increments for the first, second, and third levels of the initial inpatient care. The same exact standards are used for the subsequent observation care and subsequent care for patients that are in inpatient status. The exact same time increments apply. So they're kind of establishing that observation care is equivalent to inpatient care as far as the amount of time that physicians are expected to spend. Of course, the time guidelines really don't matter when we're billing for most of our services, because those are just rough guidelines. Most of them were established back in the early 90s. I think 1992 was when they published those time increments. The amount of time that we spend with patients has changed substantially. So with some patients, we're spending a lot less time than those time increments in the CPT code book, and that's absolutely fine. I mean, we only need to follow those time guidelines to the letter when the majority of time we're spending with the patient is spent in counseling or coordination of care, as opposed to traditional history and physical. Prolonged care is a set of codes that we don't typically bill a whole lot in cardiology, just because we have to spend this exorbitant amount of time with the patient. In 2011, they gave us some pretty clear, stringent guidelines as far as what we have to, the different standards that we have to follow when billing for prolonged care. The first thing is that they told us that the time that was being spent had to be spent by the physician. And what we see now is that in 2012, Medicare has changed it, and now they say physician or other qualified healthcare provider. So they've opened it up so now nurse practitioners and physician assistants, even though it was probably okay for them to bill prolonged care this year and in prior years, there was some people, hypersensitive people to avoiding fraud and abuse allegations and whatnot, who said, no, mid-level providers should not bill based on time or for this prolonged care. Now it's really been clarified by CPT. The other thing is that they tell us that the direct patient contact is both face-to-face time, and it includes non-face-to-face services on the patient's floor or unit in the hospital. So that kind of opens it up to make it a lot more like the time-based billing standards for hospital visits. When we're billing based on time, one of these 5 or 6 visits a week in which the majority of time being spent with the patient is just in counseling or coordination of care, like a patient with a new onset of heart failure, and the doctor spends a lot of time explaining what heart failure is and the importance of lifestyle changes, exercise, medication compliance, all this other stuff. The amount of time that we spend with the patient is exorbitant, but we might not do any physical exam on these patients. That's when we bill based on time. In the hospital setting, face-to-face and unit or floor time counts. So they've made these prolonged care times more in harmony with what those hospital-based billing standards were in the past. However, at the same time, they give us this contradiction in that, the first set of prolonged care service codes, the 99354 and 99355, are specific to office or other outpatient setting, and the other codes are specific to inpatient or observation setting. Now, the contradiction is, of course, in the fact that pretty much every place else where you look at how Medicare qualifies or classifies observation status, they consider that to be an outpatient service, an outpatient place of service. They're really clear in it that the patient is either inpatient or they're outpatient. So everywhere else in the code book and in Medicare regulations, observation would be classified as other outpatient setting, just like the emergency department, hospital outpatient department, physician office, and so on. So, they're trying to, it seems like they're creating confusion by changing around the verbiage that they've been using for years, not just in this one area, but in several others that I'll point out to you as well. But basically, observation is now, in this one context, considered to be, lumped in with the inpatient services. When a patient's seen in the hospital outpatient department or in the emergency department, apparently they're still going to consider that to be one of these outpatient places of service. So it just creates confusion in my mind. I don't know why they would just change the definitions of terms that they've used consistently for decades with no apparent benefit to it whatsoever. Another place where we're going to see some changes in cardiology, and this is pretty frequent for physicians who are doing invasive work, heart caths and or peripheral vascular studies, is with the renal angiography. So traditionally we would bill, two different components of a renal angiogram: the catheter placement, like a 36245 for first order selective cath placement below the diaphragm, and then we would bill the imaging as well, the 75722 if it was a selective unilateral study, or the 75724 if it was a selective bilateral study. Those two codes were deleted this year. The first order cath placement code 36245 was not deleted. It's still available. However, we're not going to be reporting it when we do a renal angiogram because they gave us 4 new codes that bundle all of the services associated with the renal angiogram into these individual codes. In order to understand the codes, it's important to understand that there's more than one branch of a renal artery. So the main branch, and this is the one that you're going to see, I would imagine, all, close to 100% of your services that you bill for renal angiograms, the doctor is going to go into the main renal artery. There's one on the left side of the body, there's one on the right side of the body, and they're going to do their diagnostic study from that position. They just inject the contrast, it flows downstream. It kind of illustrates what that distribution into the kidney actually looks like. Every once in a while, and this is not something that every doctor will do, but every once in a while, we'll come across a report where the doctor actually goes into one of these branches of the renal artery system. And you can see there's 1, 2, 3, 4 different branches on this diagram. If the doctor were to go into one of those branches, it basically increases their level of selectivity from first order up to second order. If we were to bill for one of these services today, as soon as the doctor goes past that bifurcation where the main renal artery splits into, the branch that goes up towards the top of the body and the branch that goes down towards the bottom, as soon as the tip of the catheter moves through that bifurcation, our level of selectivity increases to a second order catheter position. So we go from a 36245 up to a 36246. In addition to having these different levels of selectivity within these branches, some patients will also have what's called an accessory renal artery. So in addition to the natural artery that's there, or the artery that's considered to be the normal artery, some patients will have a second renal artery or even a third renal artery that are going over to the same side of the patient's body. So we have to kind of understand those two things, that there's branches to the main renal artery, and there's also some patients who have accessory renal arteries. When we look at the new codes, which are right here on slide number 7, you can see there's the two that we're going to be using virtually every single time are the ones up on top. The first one says we're doing selective catheter placement first order. So this is the reason why this is going to be the most common, is because that's typically where doctors are going to go. They're going to place their catheter into the right renal artery, into the left renal artery, and they're not going to advance it any further, up into the point where that bifurcation exists. So this is, we're doing a selective catheter placement first order into the main renal artery and any accessory renal arteries. So what this means is, whether the patient has an accessory renal artery or not, we're only going to be able to bill this code one time. For renal angiography, including arterial puncture, catheter placements, fluoroscopy, contrast injections, image processing, permanent recording of images, and radiological supervision and interpretation, and pressure gradients. It's like the flush aortograms included. It's like they're throwing everything but the kitchen sink into this one code. So if it's a first order selective cath placement and we're doing unilateral renal angiography, this 36251 code is the one code that we're going to be reporting and nothing else. If it's a bilateral procedure, again, up to the first order selective cath placement, then they give us this 36252 code, which again will be the one code that we bill. So this one code says we're placing a catheter in the right renal artery, a catheter in the left renal artery, doing our injections, doing our visualization, our interpretation. If we do a flush aortogram, it's like all of that work's included. The only difference between these two specific codes is that one's a unilateral and one's a bilateral. The codes down below are not going to be that common because these say we're doing super selective cath placement, which just simply means we're going to a second order or higher position in that renal arterial vascular family, if you will. One of these codes, the first one says unilateral, the second one says bilateral. These are not going to be that common. But when we look at how the heck we have to adjust for it in those scenarios where the doctor does go to one of those higher order selective positions, the way that you want to interpret is basically by being aware of the parenthetical notes that they give us with these new codes. So the first one here is do not report 36254 in conjunction with 36252. So what they're telling us is that the bilateral super selective code cannot be billed in addition to the bilateral first order selective code, which makes sense because we're not going to be able to bill for two separate bilateral procedures. There's only one right renal side, there's only one left renal side. Since they've clarified that the accessory renal arteries are all bundled in, there's no such way that we're going to be able to bill for two bilateral procedures. The other guideline that they give us is don't bill 36253 in conjunction with 36251, which these codes are the ones that are looking at the unilateral studies. So it says don't bill for a first order unilateral study and a second order unilateral study when performed for the same kidney. So what this tells me is that if let me go back to this diagram just for a second. So let's say we go to, let's say there's an accessory renal artery here and the doctor positions the catheter in that. That's a first order selective position. Then the doctor comes in and puts his catheter up to the point where it's actually at the second order selective position in the main renal artery. What they're telling us is don't bill for a first order selective cath placement and this second order selective cath placement if it's done on the same side of the patient's body. But what it doesn't tell us is that we can't do that or report that exact same package of codes if the first order and the second order cath positions were on different sides of the patient's body. And I believe that that's the way that they want us to bill it. Is bill 36251 and 36253 if there's a first order on one side and a second order on the other. And keep in mind, accessory renal arteries really don't matter anymore. They used to. We used to bill each of those as a separate vascular family, but now they've just bundled these in. When we're doing peripheral interventions, the one big thing that they've changed this year is embolic protection. Is that currently and in prior years, there was some, albeit limited, but there was some success that we saw with billing for embolic protection, whether we use the unusual procedural modifier in addition to the intervention that we were billing for, or if we used an unlisted procedure code to report that embolic protection that we're using in the lower extremities. In 2012, they basically bundled this into each of the interventional codes, so now it's really not going to be worth our effort to try to get paid anything extra for the embolic protection. Another form of embolic protection we need to just kind of be aware of is changing, which is these inferior vena cava filters, which a lot of people call greenfield filters. These are basically little strainers, if you will, that get positioned inside of the vena cava. When we have patients who have clots that form, a lot of times these clots will break loose and just kind of go with the flow of blood. If we allow those clots to break loose and go with the flow of blood, they're going to go to the right side of the heart, down into the right ventricle, and then off to the lung. When it goes off to the lung, it's going to cause a pulmonary embolus, which is, it's basically, it's kind of like a stroke for the lungs or a myocardial infarction of the lungs. It's basically going to create a complete roadblock so that no blood can flow past the area where this clot becomes lodged in the lungs. And that could be a life-threatening situation or certainly very painful and expensive. So what doctors can do is position these filters in the vena cava, and as one of these clots breaks off from the lower extremity and tries to travel up towards the right side of the heart, it gets trapped in this filter, and that prevents the patient from having that pulmonary embolus. In prior years, these filters would just get positioned and then they would get left in place. Now, with the special types of metals and coatings that they can put on the outside of these devices, they can actually put these in position one day, bring the patient back weeks later, and reposition the filter if necessary. And then maybe even a year or slightly more after it was implanted, they can come back and remove that filter. So sometimes patients only need to have this filter protection, this embolic protection in place, for a limited engagement, while they're not able to take blood thinners, for example, or while they recover from some form of vascular disease in the lower extremity. So what we see happening in CPT 2012 is they're basically updating the code structure to reflect that we can now reposition and also remove these filters when necessary. So you can see there's 3 new codes, all for these vena cava filters. The first one just says we're positioning it. The second one says we're repositioning it. And the third one says we are removing it. So 3 specific codes that are available for it. A lot of practices don't do those in any great frequency. But certainly if your practice is doing it, you want to make sure that you're doing it the right way. And that goes without saying. The big changes that we see that are really impacting us, and again, I know if your practice is not doing pacemaker and defibrillator surgeries, this chunk of changes isn't going to impact you. But a lot of people attending today do deal with these procedures quite frequently. The changes are substantial. We see 24 codes that were impacted. They deleted 1 code. They gave us 9 new codes, and then they played around with 14 other codes. Just total confusion is what they're creating. I don't know as if it's going to help anybody, but regardless, starting January 1st, we have to start, billing these pretty common services differently. The first thing is that they got rid of fluoroscopy. It's something that I think was anticipated for several years. We also anticipated that they would eliminate the defibrillation threshold testing with defibrillators, but they held off on it this year. It may happen next year, we'll see. But fluoroscopy for right now is not going to be separately billable. The 71090 code, the one that we typically use for fluoroscopy, was just completely deleted from the book. So it's not one of these things that got bundled into the device procedure codes. They just completely deleted the fluoroscopy for a pacemaker defibrillator implant. And they tell us that this guidance is no longer billable with lead insertion, with lead replacement, or with lead revision. So the revision is, of course, when we have to either repair or reposition a lead. They do tell us this, and I don't know as if this is going to pan out to be a very good way to bill. The more I think about this one, it's like, it may not even be worth our time. But of course, we can play around with it and see what results we get. They say that diagnostic lead evaluation without lead insertion, replacement, or revision procedures can be reported with this 76000. The scenario in which I anticipate we would use that is if we're doing a generator changeout and the doctor chooses to, pan the system to evaluate to see if the leads are in good position, to see if there's any compromise on the insulation along the course of the electrode. And just to kind of get a general sense of what the heck they're dealing with. Maybe even, at the time of a gen changeout, I know a lot of doctors will flash the pocket with fluoroscopy, which is just kind of taking a very small little fluoroscopic film of what the heck they're cutting into. We're cutting into the skin pocket, which is, the generator is right inside of it, and the leads a lot of times are coiled up inside of that pocket. Sometimes we'll want to check to make sure that the leads haven't somehow moved from lying behind the device to lying on top of the device, because when we cut into that pocket with a scalpel, if we touch that insulation on the outside of the electrode with the scalpel, it's going to slice right through it like warm butter. And all of a sudden now we have a lead that's in position and it's now compromised. If there's a compromise in that insulation, the device might not function appropriately, which could mean if it's a defibrillator, it could detect electrical activity from our pectoral muscles and interpret that as ventricular fibrillation and send out unnecessary shock to the patient. Or on the other side is that when the patient needs to have therapy, some of that energy that we're trying to send from the generator down the lead into the heart is actually going to leak out of that insulation compromise. Just like if we had a garden hose and you were to cut a gape in the side of it, when you turn the water on, it's going to be spraying out the side of that garden hose. It's the same thing that happens, except it's with electricity here. So a lot of times doctors will do this fluoroscopic inspection of the pocket. I say bill for it. You know, if they're doing it for a reason. As long as they're not doing it with lead insertion, replacement, or revision, it's a billable service, and it's a whole $8.49, which, you know, it's not a ton of money, but if they're doing the work, we might as well get them paid for it. The reason why I say I don't know if it's going to be worth it is until we start submitting the claims for these, we don't know if they're actually going to pay them or not. And if they say, well, we'll pay it only after we do a review of the medical record, to confirm the medical necessity of this and the performance of it, then, we're saying, is it worth $8.50 to hold up the claim for 3 months and to subject ourselves to an audit for this, $1,200, $1,300 procedure? The answer to that could be different depending upon who your doctors are. The initial system implant of a pacemaker system and a defibrillator system, the only big change we're going to notice is the absence of fluoroscopy on the claim. So the codes for initial pacemaker system implant and initial defibrillator system implant are still exactly the same, 33206, 7, 8, and then 33249 for the ICD implant, whether it's single or dual chamber. We're also going to be billing the defibrillation threshold test with a defibrillator implant most of the time. That's why I say we'll probably see this code get deleted in the near future. Don't be confused by the fact that they put that change symbol next to each of these device implant codes. The only reason they're doing it is because they added a little footnote down below the code definition, kind of cross-marketing a publication that's not even available yet. So they're creating this CPT changes an insider's view. It hasn't even been made available for distribution, but that's the only reason why they put this change symbol next to those 4 codes. The LV lead implants, of course, have a change symbol. The big thing that they changed with these is that they're including pocket revision with the codes for implanting an LV lead, both the one that we use virtually all the time, the 33225, which says we're putting in an LV lead at the same time that we're putting in a new generator. The 33224 is also impacted by this, and that's when you put in an LV lead and hook it up to a system that was implanted on some prior date or some prior surgery. The pocket revision codes, are these 33222 and 33223. This is revision of the pocket for a pacer is the first one, and revision of the pocket for a defibrillator is the second one. These are separately billable in virtually everything except a procedure involving the addition of an LV lead. So the key thing is understand a couple of variables. Number one is, as with everything in medicine, and especially when we're dealing with Medicare, they don't want to pay for anything that's not absolutely medically necessary, indicated, and most importantly, clearly documented that the need for that medical necessity. So the number one thing we want to make sure the doctors are aware of is tell us why this patient's pocket needs to be revised. The second thing is we need to see a description of the pocket revision. And the third thing is, when we bill for this, look at the CCI edits. They'll probably change at some point, as far as the ones that apply to these pocket revisions because of the changes that we're seeing with these LV lead codes. But right now, they bundle pocket revision into generator extraction. The CCI edit status is an indicator of 1, which means if we, in layman's terms, where the rubber meets the road, if we put a 59 modifier on the pocket revision, they'll pay for it in addition to the generator explant. What the report needs to show is medical necessity, performance of the procedure, and proof that it's separate from that generator extraction. So what I like to see in a report, I think this is a gold standard, absolutely textbook perfect, is, after cutting into the pocket, I exteriorized the device, I devitalized some tissue in the pocket, irrigated it, then I identified that we needed to expand the pocket to accommodate the larger size device that was being implanted. We did this by cutting laterally and medially into the scar tissue with both sharp and blunt dissection. That alone establishes everything that they're going to be looking for, which is medical necessity and performance of the procedure, and we've clearly delineated that the pocket revision is separate from the generator extraction. Do that, put the 59 modifier on, and they pay for the pocket revision. Probably the biggest change that we're going to see as far as the stuff that we bill the most frequently are with these generator changeouts, which are extremely common procedures. These batteries that get implanted, some of them last 8 or 9 years. Some of them only last 2 or 3 years for a number of different variables we don't want to get into. But the change out procedures themselves are some docs think they're very easy. Some docs think they're pretty hard. The changes that they've made is basically taking the work that we currently bill for, which is whatever we pull out of the patient's body, we bill for. Whatever we put into the patient's body, we bill for. So if we do a pacemaker generator change out today, we're going to be billing 33233 for removal of the old generator, 33213 for implantation of the new dual chamber generator, that would be. And if we use fluoroscopy, we'd bill that in addition to it, the 71090. Now, starting January 1st, they gave us these 6 new codes. So there's 3 for pacers, there's 3 for defibrillators. They're each the same, single, dual, or multiple chamber device is how these are differentiated. And this includes all of the work. So literally the skin-to-skin procedure might just be reported with 1 code. If we're just pulling out an old generator and putting in a new one, just these 1 codes would be applied. Now, of course, if we have that documented medical necessity and performance of the diagnostic lead inspection under fluoroscopy, we can slap that 76000 code on, get another $8.50. And if it's a defibrillator, we're also going to be billing for the defibrillation threshold testing. I mean, that's just almost always done. There's always scenarios that come up from time to time in which we won't do a defibrillation threshold test. If the procedure goes on for hours, they're not going to do it. If the patient's frail, they're not going to do it. If the patient has too much sedation already, they're not going to do it. So it's like, I think there's enough times that they don't do it to keep these codes still in existence for 2012. Whereas in fluoroscopy, what they probably saw is that over 95% of the time, doctors are billing for fluoroscopy, so they kind of got rid of that. The generator change-out codes are basically skin-to-skin procedures in and of themselves, in that they include, opening the pocket, exteriorizing the device, putting in a new device, hooking it up, sewing everything together. If we have a patient in which we do one of those, a generator change-out, and in addition to all of that work, the doctor also puts in a new right atrial or right ventricular lead. And I'm being very specific on the right side of the heart. Instead of billing for the new change-out codes, we have to go back to the codes that we're using this year. So it's kind of quirky, but a straight generator change-out is going to be clear-cut. 1 code gets us paid for everything. If the doctor has to put a new right atrial or right ventricular lead in at the time of a gen change-out, we cannot bill those generator change-out codes. We've got to bill for everything that was removed. So if it's a pacemaker generator, we'll bill that 33233. If it's a defibrillator generator, we bill the 33241. If they remove electrodes, we of course still bill the same codes for that. And then when we put new hardware into the patient's body, what we want to do is pick the package code that reflects the work and the components that we're personally putting in. So if the doctor does a generator change-out, let's say the patient has a pacemaker, and it's a dual chamber pacemaker. They have an atrial lead in place. They have a ventricular lead in place. They do the generator change out. They test the ventricular lead, and it looks perfect. Everything's working fine. They test the atrial lead, and it's got a really high impedance. So what they do is they cap that lead, and then they put a new lead in, the atrium. So when we bill for this, we first bill for whatever came out of the patient's body, which was just the generator in this case. The fact that we capped that atrial lead just means that we put literally a silicone cap on the proximal end of the lead to make it basically waterproof, so that it doesn't get any infection in the connecting head or anything like that. We put a new atrial lead in and a new generator in. So we bill for what came out, which is just this generator, and we also bill for what went in, and you really just want to kind of mentally draw a picture of what we put in. So in this patient, we put in a generator and an atrial lead. The package code that accurately reflects that is this 33206, which is the implantation of a generator and an atrial lead. Even though the patient's walking out with a functioning dual chamber device, the doctor did not put that ventricular lead in, so that's going to prevent us from billing it as the implantation of a dual chambered system. If we have a pocket revision involved, we can also bill for that with this 33222 or 33223, as long as we don't also put in an LV lead. When you do that LV lead, it eliminates the ability to bill for that pocket revision. Now, let's say we do a generator change-out, and we do not put any leads on the right side of the heart, but we do put in a new left ventricular lead. And this happens. Patient has a dual chamber pacemaker, we upgrade them to a bi-V pacemaker. Or they have a dual chamber defibrillator, we upgrade them to a bi-V defibrillator. It happens all the time. The way that we would bill for this code is to use the new generator changeout codes. The only thing that really would prevent us from using those generator changeout codes is if we also put a lead in on the right side of the patient's heart. So in this case, that's why I stress we're not putting a lead on the right side of the heart. We're only putting a lead over there in the left ventricle. In addition to billing the new generator changeout codes, we want to report the implantation of that LV lead. We're not going to bill for pocket revision no matter what. If the doctor does a defibrillation threshold test, we're going to bill for that as well. So if we put a new right-sided lead in, that's the thing that kind of prevents us from using the brand new codes, whether it's a right atrial lead or right ventricular lead, pacemaker, or defibrillator. We can't use those new generator changeout codes if we're putting a new lead in on the right side of the patient's heart. These little rules of thumb that I put together, they really do accurately summarize the new game, how we have to bill for these services. The skin-to-skin implant codes are going to be used, the 33206, 7, 8, and the 33249. We have to use those anytime we're putting a generator in and we're putting a new lead over on the right side of the heart. Whether it's an initial system implant or a gen changeout, if we see a lead on the right side of the heart and a generator, you want to go towards these packaged skin-to-skin codes. Lead extraction is billable. LV lead implant's always going to be billable. Pocket revision, it's still billable, except when we're doing an LV lead implant. And kind of keep in mind that we want to track and see how that 76000 handles under the rigors of claim processing. They gave us 6 new codes. Well, there aren't even 6 new codes. They kind of took and recycled some codes on us here, as you can see. These are not going to be used. So it's just, they're garbage. It says, we're putting in a generator and hooking it up to leads, and there was no generator in place to begin with. So it's like a patient who gets epicardial leads positioned by a cardiothoracic surgeon, and then another physician comes in and just puts in the generator and hooks it up to the leads that the CT surgeon put in. So every once in a while, your practice might deal with that, but I certainly don't think it's a common enough service to warrant 6 codes in the CPT book. It's just garbage. Everybody likes these crosswalks for obvious reasons. It's nice to kind of see this is how we bill for it today. This is how we're going to have to bill for it next year. So I just took, probably the most common device procedure codes and kind of put them together. I'm not going to walk through all of them, but I'll look at the most complex one maybe. Where we're upgrading a patient from a pacemaker to a bi-V defibrillator, and we're doing a pocket revision. So today what we would bill for is removal of the old generator, the old pacemaker generator. We're going to bill for implantation of a new defibrillator system, because when we go from a pacemaker to a defibrillator, we have to put a new right ventricular lead in place, a shocking lead. A typical pacemaker is not going to have an electrode that can be used to defibrillate the patient. So we're putting a lead on the right side. We're putting in a generator. We're also going to upgrade it to a bi-V, so that's the 33225 code. We bill for the pocket revision that was mentioned. We also bill for fluoroscopy and the DFT. Starting January 1st, it's a more streamlined approach. We bill for removal of the old generator. We bill for implantation of a defibrillator system. We bill for the LV lead and the DFT. Basically what we're doing is we're carving out the pocket revision and the fluoroscopy. Those are the 2 codes that are basically falling off. And just generally looking at how many codes we would bill currently for these common services versus how many codes we're going to be billing for these common services starting January of 2012, you can see there's fewer codes, and that's the whole concept behind how the code system evolves, is that as they see multiple services build together all the time, they kind of lump them in together and create a big package code. With defibrillators, I've got the same basic procedures listed out here. The only one I changed is down in the bottom, where I changed it to upgrade from a dual chamber ICD to a bi-V ICD. This is a quirky one, and you can see I kind of put a little asterisk next to this. So, this stuff's all new. I look at this stuff and I'm trying to make as much sense out of it as I can. There's not a whole lot of additional guidance out there. So, I think that's one of the detriments to trying to do a CPT update in November. I think the earliest you typically would find a program like this available is somewhere mid or late December. So right now, this one scenario, this is my opinion with this asterisk, is if we upgrade a patient from a dual chamber ICD to a bi-V ICD, if you think about it, what we're doing is we're doing a generator change out, and then we're putting in a new LV lead. I mean, that's the way that we're going to have to bill for it. So The question is when we bill for a generator changeout, do we want to bill for it as a single, a dual, or a biventricular ICD gen changeout? On one side of the equation, when we take the old generator out, we're only dealing with 2 electrodes. But on the other side is when we put the new generator in, we're going to be revising that pocket. We're going to be hooking up 3 electrodes to the new generator. So, you can argue that, hey, maybe this should be billed as a biventricular, a multi-chamber device is the way that they're idiotically defining these devices, giving us all new terminology. So when we do that, I think the most appropriate way to do it is to bill for the gen changeout with the code that we would use for a dual chamber system. I mean, we're basically doing a generator changeout and we're putting in a new LV lead. I believe that the work of putting that LV lead in is all included in that 33225 code. So just my impression of it is we would bill it that way. Of course, somebody that was more aggressive and not worried about fraud and abuse penalties might say, well, call it a BI-V generator changeout because that's the thing that you're ending up with. I just think that the work of putting in the LV lead is really all included in the definition of that 33225 and in the reimbursement that they give us for it as well. The errors that I've noticed in CPT are numerous. There's tons of errors that have been in CPT for over a decade. I mean, if you just, for example, look at the image that they give us for a lower extremity venogram, you'll see that they're placing a catheter high up in the groin area, injecting contrast in the venous system, and by some miracle, that contrast flows all the way down to the feet, where, of course, in the venous system, the blood is going to be flowing in the opposite direction. They do the same thing with an aortogram. They give us this diagram where the catheter's down at the lowest part of the abdominal aorta, and the contrast flows right up to above the renal arteries, which is, the blood is flowing in the other direction. So there's a whole lot of silly little errors like that that have been present in CPT for years and years and years. This year, there's a handful of errors that directly impact the new codes that they gave us. So the one thing, and I've mentioned it a few times, is when we put in an LV lead, whether it's a new system or being added to an old system, the work of revising the pocket has been included in the new code definitions. Very clearly worded in the definitions of the codes, very easy to adjust to that. As quirky as it is, it's pretty clear cut. Then you look at the parenthetical notes underneath that 33225 code, adding an LV lead onto a system that we're putting in today. And what the parenthetical notes tell us is use 33225, the LV lead implant code, in conjunction with a slew of codes, including 33222, which is our revision of a pocket for a pacemaker. So it's just total confusion that gets created, and it's kind of like, if we submit claims and there's an error here and an error here and an error here, we're committing fraud, and doctors pay huge penalties and people go to prison, and how do you look at an orange jumpsuit type of stuff? And it's like, it's Armageddon if a physician submits a claim that's got an error on it. But the people who actually create these rules are putting out stuff with errors in it every single year consistently. It's not really fair. So this is one of the errors that we see introduced. It's like we could have one web conference on the CPT changes that take place, and another web conference on the bad information that's getting distributed by the specialty societies and by Medicare and the AMA. It's absolutely mind-baffling that these errors can make their way into print in a publication that goes so nationwide in scope. Another error that we see in the CPT book this year is they kind of explain under the transvenous procedures section, they put in this chart that illustrates how we should bill for all the different pacemaker and defibrillator surgical procedures. And it just gives us a bunch of clinical scenarios and the codes that we would bill with it. A good 30-40% of these are scenarios that we're never going to be billing for in a typical cardiology group. But one of the things that jumps out is this glaring exception, which is, of course, going to save payers money, is that in all the scenarios where they explain putting in a defibrillator system, they do not mention that we should be billing for defibrillation threshold testing, and we absolutely should be billing for it. So an error that happens to be in the favor of the people who are paying these, if people blindly follow the instructions in the CPT book, they're going to be losing out on this separately payable service. So, it's an error that they left that, an omission. They also tell us that, back in 2009, they defined the difference between a single, a dual, and a multiple chambered system, whether it be a pacemaker or or a defibrillator. They basically gave us this new verbiage to run with, and they said a single lead system is one that involves, just a one lead, one chamber of the patient's heart that has pacing and sensing function. A dual lead system is one that has two chambers of the heart with pacing or sensing function. And then if the patient has three or more chambers of the heart, which there's not even a device available that paces 4 chambers of the patient's heart. It's, again, it's silly, but that they call that a multiple lead system. The thing with it is that they tell us this year, in January of 2012, they tell us that these definitions, instead of just applying to the device interrogation codes, these also apply to the whole section of codes that we're dealing with when we're talking about these surgical procedures. And that's not accurate. That's an error that they put that in there. One reason why is, let's say we have a patient who we upgrade from a dual chamber device to a BiV device, where we basically do a generator change out and we put a new LV lead in. The way that they tell us to bill for this in the new code structure is to bill for a gen change out. And again, it's, do we go with billing for as a dual chamber generator change out or a multi-chamber generator change out? And then we put this LV lead in. So these terms just don't equate in that scenario. They also don't equate when we're doing this 33214 code, which is upgrading from a single chambered pacer to a dual chamber pacer. So let's say a patient has a device in place, and it's a single chamber device, and all they have in place is a right ventricular lead. And let's say the doctor goes ahead and puts a left ventricular lead in as well, but he doesn't put a right atrial lead in because the patient has atrial fibrillation, and there's not going to be any benefit to putting in that right atrial lead. This is upgrading a patient from a single chamber pacemaker to a BiV pacemaker in the way that physicians would refer to it. If we were to follow these definitions blindly, this would still be a 33214 because we're effectively upgrading a patient from a system that's defined as a single lead system to a device that would be defined as a dual lead system. So we would bill this 33214 instead of billing it the way that I believe we should, which is to bill for that generator change out plus the addition of an LV lead. That 33214 code just needs to be deleted. I mean, that's something that I've recommended several times to the specialty societies and the AMA. It's still there. I don't think that code should be in existence. There's also a note underneath this 33264 code, and this is the code for the generator change out for a multiple chambered ICD or multiple lead ICD. What they tell us underneath this code is for repair of an implantable cardioverter defibrillator pulse generator and or leads, see 33218 and 33220. These, of course, are the lead repair codes. So the fact that they're saying these codes are applicable if we're repairing a pulse generator is just absolutely incorrect. Doctors are not going to be repairing the generators in the operating room. These are things that engineers do in very different environments than in the hospital. If there's something wrong with the generator itself that needs to be fixed, they're not going to even try to fix it. They're just going to pull it out, get rid of it, and put a new one in. That's medicine. I mean, it would be archaic to do anything other than that. Another new code that they're giving us this year is abdominal CTA. Basically says we're doing an abdomen and a pelvic study. Not a whole lot of fancy stuff to talk about with that one. This one here is a new structural heart code. So now we've got codes to address the percutaneous placement of valves. This one is for a pulmonary valve replacement, and we of course can also do it with an aortic valve. This is a relatively fast emerging field of surgery that's referred to commonly as structural heart. A whole lot of stuff that we're going to see evolve about this. It's very sexy, very exciting. So, traditionally if a patient had to have a valve replaced, it was a pretty extensive procedure, and we're talking, if you think about what you got to do just to get to the point where you can cut out an old valve and put in a new one. It's like it's a major open chest bypass type of a procedure where we're very, very risky, a lot of work, a lot of risk of infection, so on. There's devices on the market and coming on the market that allow us to do these things percutaneously. So we're kind of going up there with a very fancy type of a catheter that has the ability to, put this new aortic valve, or in this case, pulmonary valve, in place. So this is something, again, I don't know as if everybody's dealing with this right now, But if we go 4 or 5 years into the future, I think you're going to find a lot of your doctors talking about it, and of course, a lot of them are going to start to specialize in it. A left atrial appendage placement is reported with this new code. This is percutaneous transcatheter closure of a left atrial appendage. So in the left side of the patient's heart, we've got the left atrium itself. There's also like a little kind of like a smoking room off to the side here is kind of how I like to think of it. It's really just like a little cavernous area where, if a patient's in AFib, their heart is basically not squeezing and relaxing and squeezing and relaxing. So what happens is the heart just kind of sits there and quivers. When the heart's quivering for an extended period of time, specifically 72 hours or longer, the blood that's inside of that appendage starts to turn into a big fat clot. And if that clot were to break loose, it's going to go down into the left ventricle and then get squeezed out through the aortic valve and go right up towards the brain. I mean, the first 3 big turns it could take at the top of the aortic arch will carry that clot right up into the brain, and that will of course cause a stroke. So what doctors will do a lot of times is if they can't do an AFib ablation, or sometimes they'll do this in addition to an AFib ablation, is they'll actually just kind of put this it's sort of like a very fancy seal over the opening of that left atrial appendage. That way we allow that clot to form, but we kind of corral it and keep it in that left atrial appendage so it can't do any damage downstream. So this is the code for that. Again, not everybody does it, so I hate to spend way too much time on it. The abdominal aortic aneurysm code changed a little bit. It became less specific. So, traditionally, or last year anyway, this code essentially says it has to be a fenestrated modular bifurcated prosthesis with 2 docking limbs. They just kind of got rid of all of those specifics going into 2012. They made it a much more kind of like a user-friendly code, if you will. A really exciting thing that and it's also really time sensitive, and I hope people on the call today are as excited about it as I am, which is this opportunity that we have to, probably as directly as we've ever had an opportunity to before, to directly influence all of these stupid rules that we deal with. And I love this John Kennedy quote I heard once, which was, just because we don't agree with a rule or don't agree with a law, that doesn't mean that we have the right to violate it. So, that's been my approach for my whole career is, we really need to understand the rules to the point that we can follow them in practice. But a lot of the rules are really stupid. What we've seen, or what we see right now, is this opportunity to directly influence the elimination of rules that are stupid, the correction of rules that are unnecessarily arbitrary, and in some cases maybe even the creation of new rules that make life simpler for us. It all started with this executive order, and this is something that I encourage you to just Google it. I mean, Yahoo it, Google it, whatever you want to do. Is just type in Executive Order 13563 and it'll come right up for you. In this executive order, the president basically said that our regulatory system needs to work for the people. The words that I highlighted here are really important. It says the regulatory system must be based on the best available science. Right? This is really key to me. I'm a huge advocate of evidence-based medicine, and it must allow for public participation. They also said it must ensure that regulations are accessible, consistent, written in plain language, and easy to understand. He also said that all agencies, and this is, we're mainly focusing in on the Department of Health and Human Services, all agencies consider how best to promote retrospective analysis of rules that may be outmoded, ineffective, inefficient, or excessively burdensome, and to modify, streamline, expand, or repeal them in accordance with what has been learned. So this is an executive order from the president to the Department of Health and Human Services. What they did is they published this proposed rule, which proposed rule is just what it is. This is how they're proposing to respond to it. You can find the proposed rule at this direct web link right here. You're going to be let down when you see what their initial thoughts are. They're like, okay, we've got this executive order to streamline all these burdens. And it's like you read through it, and all they're addressing is like durable medical equipment and nursing home orders and just stuff that's just absolutely, not that big of a deal. But in their proposed rule, it says this. It says, if at any time members of the public identify possible reforms to streamline requirements and to reduce existing burdens, the Department of Health and Human Services will give those suggestions careful consideration. Therefore, along with this proposed rule, we seek ideas from the public to help identify areas for possible reform. You're not going to get a much better invitation to voice your grievances with all of the stupid rules that Medicare has than this. The beauty of it is that the number of ideas that just come rushing in our mind when we're presented with this opportunity. Just think about all the rules that Medicare has out there, all the contradictions that exist. I pointed to just a couple of them today, and as you know, there's hundreds, maybe even thousands of contradictions just in the set of rules that we have to deal with in billing for cardiology services and the indications for services and how we document and bill for visits and things like that. There's just a ton of ideas. This is a list of my initial pass at it. I'm going to be spending a lot of time on this in the next month, putting together a very well worded and thorough assessment and summary of what rules I think need to be changed. And I'm going to be submitting them before this deadline, which I'll explain to you in just a second. One thing is the E&M documentation guidelines. I don't think we need to have these in place anymore. I mean, if we talk about what are things that distract physicians from patient care, cost extra money, and ultimately do not help improve the financial welfare of the healthcare system, the E&M documentation guidelines comes right to the top of my list. I think the guidelines are arbitrary. They're garbage. They have no influence on patient care. They just create a tremendous distraction for the physicians, and they force doctors to spend a boatload of money on software and electronic medical record programs and attending sessions and having audits done and attorneys and compliance programs. The E&M documentation guidelines are garbage. Everybody knows they're garbage, but at the same time, the government's aggressively penalizing if we don't follow them. That's right on the top of the list of things that just needs to be completely eliminated. The educational letters that they send out about these bell curves. They say you haven't done anything wrong. This is just an educational letter to let you know you're billing more 99214s than your peer group. That's garbage because the peer group that they compare us to is the general cardiologists across the country. The overwhelming majority of cardiologists are non-invasive doctors. So when they compare a doctor who's perhaps an electrophysiologist or perhaps a vascular interventionalist, when you compare them to the national average, of course it's going to look like they're billing more 4s or 5s than everybody else. The national average that they compare us to also includes all the nurse practitioner and physician assistant and registered nurse services that are being billed incident to a supervising physician. So, I mean, if you look at the national data about how many times cardiologists bill their 5 different levels of established patient visits, there's this huge spike at the 99211 level. Not a single one of those was provided by a physician. They're all nurse visits. So the bell curves that they're using to scare physicians is a huge distraction from patient care. Another huge one is this ACC National Cardiovascular Data Registry for Primary Prevention Defibrillators. It's an absolutely a flawed effort to try to identify which subset of the patient population would best benefit from a defibrillator. All the garbage that goes into this is known at the time of the implant. So we're trying, Medicare originally said we want a registry that will allow us to do a retrospective analysis of how defibrillators perform in practice so that we can hone down the indications list to a more appropriate subset, which is a noble effort. It's almost like a clinical trial, if you will, except it could be really good because 100% of the patients are getting enrolled in it. The problem is that all the data that the ACC has dictated to go into this registry is known at the time of the implant. So we're trying to figure out which defibrillators actually work and which ones don't work. We'd want to know when these devices shock and save the patient's life, and also when a patient dies and doesn't receive therapy that could have saved their life. If a patient gets a defibrillator implanted right now and they go out to the parking deck to try to find their car, they get frustrated and they go into ventricular fibrillation and the device shocks them and saves their life. That's a patient who we would definitely want to earmark as being one who benefited from the implant. That event is not going to go into this ACC National Cardiovascular Data Registry. It's garbage. It takes a lot of administrative burden to enter data into it. One of the things I think they should just eliminate, they should also get rid of modifiers, a lot of modifiers. The 25 modifier, it's stupid. It says we're providing a visit on the same day as a procedure. Well, the fact that we're billing for a visit on the same day as a procedure does everything that they need. We shouldn't have to put this 59 modifier on. They tell us there's CCI edits. Well, we got to know which of the edits to put the 59 modifier on, which ones not to. The 51 modifier, Medicare said we don't need anymore, but it's still there. The 24 modifier says we're billing for a service in the post-op period that's separate from the routine post-op. We wouldn't be billing for it if it wasn't. It's just administrative burden. I think ICD-10 should just go away. It's one of these things that everybody is just so nervous about. We're spending so much money on, and it's not going to happen in 2013. I mean, everybody keeps saying that. It's not going to happen. It's just absolutely not going to happen. I think they should just get rid of it, table it for another 5 or 10 years, and let us just deal with fixing the system at hand now. The Incident 2 rules are stupid. They should just not give us a 15% cut if a mid-level provides this service. We need to incentivize mid-level providers to practice more because there's a terrible shortage of physicians in the country. The Medicare administrative contractor discretion to create LCDs, that should just be gone. I mean, it's Medicare. It's a national health care program, if you will. They should all follow the same coverage policies, and they should all be based on evidence-based trials. One of the biggest places where we see, coverage determinations that are just way out of date are the pacemaker and defibrillator indications. The pacemaker ones were last updated back in 1983. The defibrillator indications have never, ever been reconciled. There's so many contradictions in them. The Department of Justice is having a heyday with them. And the people who physicians expect to defend them are actually working with the Department of Justice. Namely, the Heart Rhythm Society is working in conjunction with the Department of Justice in their prosecution of physicians who are putting in defibrillators that fall outside of this obscure riddle of what they call the coverage indications for a defibrillator. It's not fair. The physicians are being distracted from patient care, and the national standard is not in line with evidence-based practice. That's another thing that's definitely on the list. So here's how you can participate. And I'm not the spigot that everything goes through. I'm not the AV node that's going to filter out things that shouldn't get in. You can directly submit any comments you have, any suggestions you have about what rules you think could be eliminated that will help further the government's goal of eliminating administrative burdens, saving healthcare system money, and allowing physicians to focus on patient care. And there's a lot of them out there. Everybody should really participate. And I also encourage you, if you participate on, listservs or if you have professional societies in your town, share this information with everybody. I mean, this is our opportunity to help streamline the regulations that apply to how we bill for services. We will have a substantial impact on the quality of health care and the reduction in administrative burden if people take this seriously. We have until December 23rd. So we've got enough time to really, have a nice grassroots effort here. If you don't do it now, when are you going to do it? When are we going to have an opportunity again to directly comment on things where the government's going to be reviewing all of these comments in a meaningful way? So you can do it 3 different ways. Electronically, you can go to this website, so you don't even have to have postage on it. You can send it by regular mail, or you can send it by FedEx or UPS or overnight mail to this address. So there's 3 different ways that they'll accept the comments. In your handouts, I, of course, gave you the links to all these official government documents. But as you read through them, it's like, don't burn them off because this is a waste of paper. I mean, it really is. Like the proposed rule, they're saying, oh, we're going to save, $5 million over 5 years if we get rid of this, nursing home assessment form that's actually a duplicate. It's just, they're way off base with what they're starting in on. But I believe that the people on this conference call, we've got several hundred people on the call today, really, really good people, very, very focused on doing the right thing, not at all focused on doing anything inappropriate. We understand that there's a lot of broken rules. This is our opportunity to comment on it, and hopefully the government will take it seriously and fix it. If they don't, at least we'll feel good knowing that we tried. Lastly, make sure you visit my website. We're trying really hard to bring a lot of value and to help physicians out. I've got a growing library of on-demand web conferences. Today's web conference was recorded. I'm going to try to make it available in the next week or so for people to view if they want to. I have a membership newsletter. It gets published maybe 10 or 12 times a year, and it basically helps elevate the level of proficiency among your coding and billing staff in a trackable way. People get this newsletter. There's an online test that goes with each of them, and the administrator of your practice can see the report cards from each of the people who are taking the test. Also, keep Cardiology Coder in mind for any chart auditing services that you need, whether it be a prospective review or if you get subject to one of these RAC or DOJ investigations. A lot of members have successfully appealed denials and eliminated penalties by having me work with them to help walk the regulators, the people who are doing the audits, through the process to identify that we actually are billing for these services correctly. The people doing the audits are not the sharpest tools in the shed always, so it actually helps to piece it together for them to do it like a paint by numbers, and that's something that we're very good at. So please keep me in mind. Thank you very much for joining the call today. I absolutely appreciate it. I respect your time, and I appreciate this opportunity to be of service. That's all for now. Thank you very much, and have a great weekend, everybody. Bye-bye.